Hello, everyone. Thank you for joining today's webinar, Medicare Solvency Projections and Potential Solutions. I'm Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. For those of you who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And the Alliance for Health Policy gratefully acknowledges the Commonwealth Fund for supporting today's webinar. And I have some quick housekeeping items, and then I'll introduce our moderator. So I want to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. And we want you to be active participants in today's discussion, so please be getting your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. And you can use that to submit questions you have for the panelists at any time. We'll be collecting these and addressing them throughout the broadcast. And you can also use the chat to send any technical issues that you may be experiencing. And then finally, please be sure to check out our website, allhealthpolicy.org, where you can find background materials, including a resource list and an expert list, and then a recording of today's webinar, and the slide deck will be made available on that website soon. And now I am so pleased to introduce Dr. Gretchen Jacobson to moderate today's discussion. She's the Vice President of the Medicare program at the Commonwealth Fund. Prior to joining the fund, Dr. Jacobson was at the Kaiser Family Foundation, where she served as Associate Director of the organization's program on Medicare policy. And she was also an analyst in healthcare financing at the Congressional Research Service and holds a doctorate in health economics from Johns Hopkins Bloomberg School of Public Health. So we could think of no one better to lead this conversation. And Dr. Jacobson, I'm very pleased to be leaving this discussion in your expert hands. So thank you for joining us. The discussion is yours.
Wonderful. Thank you, Catherine. As Catherine said, I'm Gretchen Jacobson and Vice President of Medicare at the Commonwealth Fund. For those of you who aren't familiar with the Commonwealth Fund, we're a private foundation focused on advancing access to affordable, equitable, and high quality care for all. As we all know, the Medicare program serves a critical role in our healthcare system by helping to provide health and financial security to some of the most vulnerable people in our society, while also acting as a strong lever for innovation and a catalyst for change for the broader US healthcare system. The Commonwealth Fund's program on Medicare supports research and analysis on the health needs of beneficiaries, models of care delivery, and ways to ensure equity in the care provided. Over the last year, we've also taken a closer look at how to ensure Medicare remains solvent and able to meet the needs of current and future beneficiaries. Through this work, we've highlighted a range of policy options and supported modeling of some of these to understand the implications for beneficiaries and healthcare providers, as well as federal spending. So next slide. Just 2 weeks ago, the Congressional Budget Office released their updated economic outlook that projected the Medicare Hospital Insurance Trust Fund will be insolvent in 2026 and will not be able to fully cover the cost of beneficiaries' hospital bills. That's just 5 years from now. To put this into context, this is the shortest period until projected insolvency since 1997, 24 years ago. As you can see in this chart, solvency projections have greatly varied over time, with different pieces of legislation helping to extend the life of the trust fund. As we will discuss, the trust fund projections are a function of not only healthcare spending and money flowing out of the fund, but also the economy and the amount of revenue flowing into the fund from payroll taxes. So today we have a fantastic panel who are here to talk with us about the solvency of the trust fund and how discussions around solvency can also provide the opportunity to ensure the Medicare program is meeting beneficiaries' needs. Our first panelist is Corey Uccello, who is an actuary and senior health fellow at the American Academy of Actuaries. In this role, she promotes the formulation of sound health policy by providing nonpartisan technical assistance to federal and state policymakers and regulators. She served 2 terms as commissioner of the Medicare Payment Advisory Commission, or MedPAC, and was a member of the 2010 and 2011 Technical Review Panel of the Medicare Trustees Report. Next, I am pleased to introduce John Blum, Vice President and Managing Director of Medicare at Health Management Associates. He has more than 20 years of senior level experience working in public and private healthcare financing organizations, including, of course, CMS. And finally, I'm pleased to introduce Dr. Adeze Enegwechi, a Research Associate Professor of Health Policy and Management at the Milken Institute School of Public Health at George Washington University. He most recently served as the president of IMPAC, a policy research and implementation company, and she also serves on the board of the Alliance for Health Policy. Thank you for joining us. We're going to start today hearing from Corey. And Corey, I'll turn it over to you.
All right, thank you, Gretchen, and welcome everyone. If I could have the next slide, please, and the next one. So I'm here today to give some information about the basics of the Medicare Trust Funds and the solvency picture. So there are actually 2 Medicare Trust Funds. The first is the Hospital Insurance Trust Fund, or the HI Trust Fund, and that covers inpatient hospital and post-acute care under Medicare Part A, and it's financed through payroll taxes. The other trust fund is the Supplementary Medical Insurance, or SMI Trust Fund. It covers benefits under Part B, that's the physician and outpatient care, as well as the Part D prescription drug program. And the SMI Trust Fund is financed through beneficiary premiums and general tax revenues. Now, a lot of focus right now is on the HI Trust Fund, and this next slide tells us why. If I can have the next slide, please. Whoop. If you can back up, yep. So currently and and hereafter, income or expenditures under the HI Trust Fund exceed the income coming into the trust fund. Over the next few years, assets that have accumulated in the trust fund will be drawn down in order to meet that deficit. However, after the trust fund is depleted in a few years, there won't be enough money coming in to pay for all the benefits going out. Next slide, please. So when is that going to happen? So recent depletion dates that have been projected from CBO and the Medicare trustees have ranged from 2024 to 2026. And the reasons for these fluctuations has been uncertainty about COVID-19's effects on spending and payroll taxes. In the short term, there were reductions in benefit costs due to people deferring care. However, that's rebounded and utilization is returning. Payroll tax revenue has declined due to the economic downturn. The bottom line, though, whether we're talking about a depletion date of 2024, 2025, or 2026, it doesn't really matter here. The depletion date is really just right around the corner, whichever of those dates it is. Next slide, please. So what happens when the trust fund, nope, if you can back up one. What happens when the trust fund is depleted? Well, the 2020 Medicare trustees estimated that when the trust fund is depleted in 2026, revenues coming into the program would cover only 90% of expected expenditures. And that deficit over the next 75 years would amount to about 0.75% of taxable payroll. Eliminating that deficit over the next 75 years would require either an immediate 26% increase in payroll taxes or an immediate 16% reduction in expenditures, or some combination of the two. And I just want to highlight here that these are the changes that would be needed if action were taken right now. If action is delayed, that would require larger increases in payroll taxes or reduction in expenditures. Now, it might be too heavy of a lift to address the whole 75-year deficit. So if we look at what would be needed over the next 10 years, that cumulative shortfall in the trust fund is about $500 billion. Next slide, please. It's important, though, to think about Medicare's financial condition beyond just the HI depletion date. We need to think about the spending and the income for the program as a whole. So for example, the SMI trust fund will remain solvent, but only because its financing is reset every year to make sure that the revenues coming in are enough to meet the expenditures going out. But those increases in SMI expenditures over time mean that we'll need significant increases in beneficiary premiums and general revenue contributions. Next slide, please. And we also need to think about Medicare sustainability beyond just solvency and financial challenges. We also need to think about whether the program is meeting the needs of the beneficiaries in terms of benefits coverage, what the out-of-pocket costs are for beneficiaries, and in terms of racial and ethnic disparities. So in sum, policies should aim to ensure that Medicare beneficiaries have access to high-quality health care that's affordable both to them and to the nation as a whole. So I'll leave it there and pass it on to John.
Great, thank you for the opportunity, and I really want to build on the comments Corey talked about. You can go to the next slide, please. One more slide. I really want to echo some of the points in this first slide that Corey was making. I think the first point is that if Congress decides, and will have to decide, to address the solvency issues, that the dollar size to these changes are much bigger than really considered before in the past. To our estimates, Congress would need $500 to $600 billion during the next 10 years just through Part A policy changes. These dollars are massive, they're huge, and much bigger than Congress has considered during previous discussions regarding Medicare solvency. This doesn't even include Part B changes, Part D changes that Congress may choose to consider. And I think just to build to Corey's point, that if the trust fund does go insolvent, there are real consequences to how hospitals get paid, how post-acute care providers get paid, and Medicare private plans, they get paid through the Part A trust fund too as well. But given these massive changes that are needed to address solvency, we also think that it's very important to say again Corey's points, that these changes not only affect the trust funds, but they have direct consequences to beneficiary benefits, their cost sharing, their premiums, but also to the finances, how healthcare providers get paid, hospitals, post-acute care providers, which really kind of causes us to think about the need for a more comprehensive scorecard to really assess different policy choices. Depending on their design, depending on their structure, they're not only going to affect Part A trust fund balances, but they'll also affect different providers, different beneficiaries, and those that have greater need. Those providers that are more dependent on dollars coming from the Part A trust fund will have differential impacts depending on the policy structure and how Congress chooses to build those policies. Next slide, please. So through the work that we did for the Commonwealth Fund, we have constructed what we're calling a kind of unified, comprehensive tool to assess Medicare policy changes. The goal here is for us to take policies that could affect hospitals, that could affect benefits, that could affect how the program really gets financed, and to build measures that not only assess the overall finances, but also assess how these policies will shape hospital finances, paying particular close attention to those hospitals that are more vulnerable to Medicare policy change, DISH hospitals, rural hospitals, but also to assess which beneficiaries, depending upon their participation in the program, whether they're in the fee-for-service program or belong to a private plan, whether they have high need, low need, whether they're high income, lower income, to really assess their own particular kind of fate through these policy changes. And our goal is to take different policies and really, run them through different models to assess those particular impacts, depending regarding whether they're providers, beneficiaries. So just taking one policy, we're not here to say this is the right policy, but just taking one policy that would change how plans get paid and to change the kind of overall structure from the current structure to one where plans get paid based upon their bids. We want to ask kind of three questions. The first question being, how does it change the overall financing to the program? This policy, given its current design, would save $470 billion during the next 10 years, but only change the solvency by 2 years, because this policy would save both Part A dollars and Part B dollars. With lower Part A, would change per capita spending by about 1%. We don't think this is going to change how providers get paid, really, with the assumption being that plans pay the same amounts as the traditional fee-for-service program, but the real impact happens to Medicare beneficiaries. We think, given this construct, that fewer plans will choose to participate within the program. That'll change beneficiary spending. Plans generally provide more cost-sharing protection than the traditional Medicare program. As plans begin to pull out, more beneficiaries will be served by traditional Medicare, and those that have poor health and have greater health care need will tend to pay more. So the goal here really is to kind of illustrate that these changes will have differential impact, particularly those that have large dollar impacts will really begin to affect beneficiaries differently. So we think it's very important, one, for Congress not only to fully understand the dollar impact, but also to understand which beneficiaries, which providers really will have the most impact, as we can see about these very difficult trade-offs that Congress will have to make. So with that, I'll stop and then turn to the next panelist.
Okay, thank you, John. And again, thanks to the Alliance for Health Policy and to the Commonwealth Fund for hosting this webinar, and to the Commonwealth Fund for the blog series that teed up this conversation. My name is Adenze Inefuchi. Next slide, please. And I want to move us into, next slide, into an area of discussion that I think comes up perhaps less frequently than some of the puts and takes that we often hear about in the Medicare program. Corey has set us up quite nicely with an explanation of the Medicare Trust Fund, Part A, and Part B, and the fact that insolvency is essentially in policy terms imminent, whether it's 2024, which is an escalation due to COVID, according to estimates, or 2026. It feels like at the side, given the size of this policy concern, as John nicely laid out, $500 to $600 billion insolvency over the next 10. In terms of what the shortfall would be, we're talking about an issue that requires a policy response that probably should have started yesterday. So it's an opportunity, I think, for us to discuss the broader structural issues that afflict the Medicare program, both in terms of spending and, of course, in terms of financing. So that's what brings us to this topic of health equity. What is it, and is it relevant in Medicare? So just an opportunity to level set. Health equity is achieved when everyone has a fair opportunity to attain their full health potential, and no one suffers from any disadvantage in their opportunity to achieve that goal. I think it's fair to say that most of us know that many vulnerable people do not enjoy a fair opportunity at optimal health. And this, of course, is irrespective of what type of healthcare coverage you have. So it's an important point to level set. There's an unfortunate misconception that health disparities are an issue only in Medicaid. It's a puzzling misconception because we know that opportunities to advance health and improve your health exist in the commercial space. It exists in Medicaid, and it certainly exists in Medicare. KFF, or the Kaiser Family Foundation, just published a report last week showing with some findings that show the extent to which we have an issue in the Medicare program and therefore an opportunity to improve. So in order for the Medicare program to design a system that is responsive to beneficiaries' needs, the program has to confront the poor health outcomes that are often caused by lifelong effects of racism and structural inequities in the United States. And that's what I think is nice about this opportunity to have this broader discussion about Medicare in general. Next slide, please. So next slide. Thank you. As I mentioned, the insolvency discussion presents us with this, back please, presents us with, yes, an opportunity to have a broader discussion. 2020 and COVID has shown all of us that inequities exist in access to care, in information, and of course in outcomes. Again, with this public health emergency and catastrophe really highlighting how wide these gaps are. Vulnerable populations suffer consequences. Vulnerable populations suffer consequences that I think are even more magnified because of their vulnerability. For example, I think we just saw this week that life expectancy was, 1 year was shaved off of the general population's life expectancy. But I might have been logged off. I hope people can still hear me. But for African Americans, the loss in the years of life expectancy was 2.9 or 2.7 years. For Hispanics, it was 1.9. So again, we find that depending on how you define vulnerability, it's any sort of a calamity tends to hit vulnerable populations much harder. 40% of Medicare beneficiaries do not have broadband to access. So if we are thinking about infrastructure in the Medicare program, which was one of the main routes to securing any sort of care in 2020, a good chunk of Medicare beneficiaries were left off of that train because they didn't have broadband, they couldn't participate in video conferencing, which is still the bulk of telehealth and telemedicine today. So this discussion, it requires a major policy effort to incorporate or to develop both short and long-term policies to strengthen the Medicare program. In terms of short-term fixes, there are many that we can discuss. A bunch of them are in the blog post that I just referenced. But We can think about Congress making up, policy decision to go all in on site neutral payment policies, or to do something about drug prices, to negotiate drug prices, for example, or my favorite that I just read from Richard Frank and Thomas McGuire, clawing back some of the windfall from MA plans that they realized in 2020. There are a lot of things we can do to shore up the Part A trust fund and perhaps even Part B across the program in the near term. But the longer term discussion around what to do about health, the demand for health among some of the most vulnerable, the sickest, beneficiaries, the folks who have predisposing social and economic conditions that leave them much more vulnerable to any breaks in care or to gaps in the system. That is a conversation we need to start having in the Medicare program. Next slide, please. Great. So what to do? What should Medicare's role be in advancing health equity? Let me preface this slide by saying that it actually feels overwhelming, especially for people who have not been living in this space in research for many years. When you're talking about social, structural problems that often are not related to health, it feels overwhelming to think about how we deal with it in the healthcare space. And I also think that we should preface this slide by saying that we won't solve every social problem in healthcare. Every social sort of breakdown in housing or transportation can't be addressed entirely in the healthcare system, and that's not the point. But a lot of talk, I think, signals the right intention, which I have to give the policy community credit for, but talk isn't necessarily equal to action, and that's where we need to start working on in the very near future. Healthcare has a role to play. Medicare certainly has an opportunity to lead, which leads me to my first point. Medicare has an opportunity to lead in the discussion around health equity. We can take the lead in rethinking how we define network adequacy for populations that have diverse set of needs and structural gaps in terms of where providers tend to locate. We can think about how we incentivize physicians and other providers in value-based frameworks that we're developing and refining right now. So there are a lot of things we can do, but the issue is Medicare has an opportunity to take the lead in this space. The second thing is to incorporate dynamic screening for social factors. The revenue model for this hasn't been fully sorted in the private sector, so perhaps it's an opportunity for Medicare to test and incorporate some screening, dynamic screening for social determinants of health. Vulnerable people don't just have one gap. They tend to have a cacophony of challenges. And if you don't document and measure and account for them, it's hard to know what you're supposed to be solving for. Can't solve for what you don't know. So there's a great need to incorporate that as we think about payment systems in the Medicare program. The third point here is to combat implicit bias and enhance cultural competence among providers. There's a big gap between discussions about this and experiences in clinical settings. Many people of color, irrespective of socioeconomic status, so it could be rich, it could be poor, do not feel listened to. They are often dismissed. Their concerns are not always attended to when they interact with clinical, with clinicians or in the clinical setting. There's some high-profile examples I'm sure many of you have read, but it's important to note that those are not one-offs. These tend to be quite universal among people of color, among people who speak English as a second language. And there's a huge opportunity for Medicare to take the lead in recognizing this and instituting training, clinician training in this space to help mitigate against what we now know could be a huge barrier to adherence, to trust, and everything that we know presents a challenge when we need to then sort of implement public health measures. The fourth thing, and I'm going very quickly here, is to use all of the data that we can collect and that we have: socioeconomic, encounter, claims, clinical data. In Medicare, we tend to default to claims data because that's what we have readily available. but it's rare to see a claim on any one individual over a 12-month period that tells you everything you need to know about that person. So it's amazing, I think, what you can learn when you bring on some of the survey data, and what I hope we can begin to collect around social determinants of health, again, to paint a fuller picture and understand how perhaps the healthcare setting can be the hub for what would be a scope, a spoke, if you will, of other community-based providers to help fill out what we hope would be a more responsive payment system. And the fifth, but not the least, of course, is to harness technology in the delivery of care. Technology is necessary. It is an inevitable component of how we will deliver care in the future. I think the payment system has a lot of work to do to catch up. And I as an analyst here, I understand what the challenges are. But at the same time, I think from the beneficiary's perspective, one good example is if a 40-year-old is struggling to sign up with a system that's been developed to sign up their 75-year-old parent to receive the COVID-19 vaccine, and the system is, not user-friendly. Can you imagine what it's like for the 75, 85-year-old Medicare beneficiaries that we're expecting to navigate pretty complex and difficult to use systems? So we have the conversation around technology is broad and rich, and we have a lot of work to do in that space in terms of leveraging how we use it to address health equity concerns. And with that, I will turn it back over to Gretchen.
Sorry. Well, thank you so much, Adesi. That was really terrific, all of you. Now we'll take questions from our audience. And remember to use the questions panel also to submit your questions at this time. So while the questions populate, let's start first with one of the biggest questions. What happens if the trust fund's not addressed? I think we've talked a lot about the importance of the trust fund and that this is really critical, but what happens if it's not addressed?
So I can take that. So if we go by the Medicare trustees estimate that 90% of expenditures would be able to be covered by payroll taxes, what that means isn't that people would only get 90% of their care or something like that. What it means is that providers would be delayed in getting their payments. So people could go to the doctor, but the provider it might take a little while. They have to wait for the payroll tax revenue to come in so they can then pay the provider. So that's generally, technically what would happen. The question then becomes though, what are the impacts of that? Do people then face delays in getting care because providers are getting delayed in their payments? And if that's the case, then it's the people who have higher health needs that are going to face more problems. So people with high health needs, more vulnerable groups may potentially have more problems accessing care.
I think just to add to that, the law is silent to what happens when the trust fund runs out. There's no kind of playbook that would describe the operational procedures. And I think we can only speculate what would happen if funds weren't there to pay current benefits. I think one risk would be that providers may decide not to take Medicare patients or to really kind of backlog care, or potentially health plans may choose not to participate within the program.
If I can just echo one of the points Corey just raised, I think it's helpful to play that out. If there are delays in care, who are the folks who are most likely to suffer the gravest consequences? It's likely the more vulnerable, the folks who could least afford gaps in care. This is one of the questions that's asked in the Medicare current beneficiary survey.
Adesi, I think you'd cut out on us. Okay, well, Hopefully Adeze will be able to tune back in with her internet issues. Sorry about that. Let's turn to another question, and hopefully we can get back to Adeze's point. How does focusing on the trust fund overemphasize certain approaches over others in some ways? With a lot of the focus on the hospital insurance trust fund, are we sort of overlooking other approaches for improving the Medicare program? Oh, great, Adeze's back as well.
I don't know how much of what I said you heard, but.
Corey and John, do you want to jump in and answer that? Of how does focusing on the hospital insurance trust fund really, in some ways, might force us to overemphasize certain solutions?
Well, I'll start, and then John can come in again. So if we're focused on HI, then we're going to be focused on the providers and the benefits that are in HI, as well as the revenues that are coming in. So that's going to lead us to focus on hospitals, on payroll taxes, and look at solutions that address spending in that area, which looking at those things, may be appropriate, but we're ignoring a whole other set of things that might help improve the program. So some of John's work he's looked at, and others have recommended looking at site neutral payments, which make a heck of a lot of sense, right? But they don't help the HI trust fund at all, even though they can reduce spending. It's spending in Part B. The other thing I think that looking just solely at HI is that it creates some kind of weird opportunities, I guess it's not quite the right word, to shift costs from Part A to Part B. Well, that might help the HI trust fund, which is fine, but it doesn't lower Medicare costs overall. So it's the way it's structured. So, we need to look, and that's why we keep saying that we need to look not just at HI and what makes sense for bringing that trust fund into better financial status, but what makes sense for the program as a whole.
I think just to add to that, the Part B side currently is projected to grow faster than Part A, and due to the choices that Congress made back in 1965, there's two different mechanisms that have two different rules, but it doesn't necessarily get to which services really have the highest growth pattern, that have the highest spend, that have the highest burden on beneficiary cost sharing. Beneficiaries pay relatively low cost sharing for Part A services. So I think there really needs to be this more balanced scorecard, more balanced set of both financial measures, provider measures, beneficiary measures, to really assess the true solvency questions. But if you just take a kind of pure spending perspective, Part B is currently growing faster and may have the more kind of budget pressures, but not necessarily the same solvency type issues.
Right. So talking more about how this ought to be addressed, what are sort of the pros and cons of taking more of a, given the size of the amount of changes and savings that would need to be achieved to significantly extend the trust fund, as John has said, what are the pros and cons of taking more of a piecemeal approach versus a bigger, larger approach to this?
I think it really gets back to the goal. So if the goal is to extend solvency and to extend the kind of crisis period or really push it out, policies that have bigger savings during the first kind of several years will have more solvency delay. If the goal really is to address the overall cost of the program, to address the overall fiscal situation, given how Medicare currently is paid for, than policies that tend to be structured more carefully, more piecemeal, may have more kind of policy sort of sense going forward, given the dollar size, given the rationale. But just regarding the math, that if the goal is to really delay solvency 10, 15 years, then you need to really think about sizable changes. You need to think about more kind of earlier changes. That's very difficult to do just to find those savings, given the current dollar size, which may argue that Congress will really have to take more of a kind of stepwise approach to ensure that policies don't create huge disruption as large policies can do.
And I'll add on to that we really need to think about whether we're doing everything at once or doing things more incrementally. What is our ultimate goal of what we want this program to look like? And you could get there by making big changes at once, or you can get there incrementally. But if we're just have this focus on solvency or things like that, and we just like implement a whole menu of things that save money that are coming from different options and different silos, then it's not necessarily getting us to where we want to be in terms of what this program should look like. And so I think we need to think about that too as we're moving forward. And John's tool, I think, really tries to get at that a lot by looking at a lot of different metrics rather than just the solvency. But where is it that we ultimately want to be? And unfortunately, I don't think there's necessarily agreement on that. But making sure that things that we're putting in make sense toward that goal, I think is important.
I don't even think we've had a full-fledged discussion. I'm sure my bandwidth will kick me off again. So if it knocks out my video, that's fine. But Corey, just agreeing with you, I don't think we've had a full-fledged discussion as to what the options are. It's hard for me to see Medicare long-term in its current structure. As more people age into the program, as people live longer with more serious chronic conditions over a longer time frame, the current financing structure, and we haven't touched on revenues very much so far, but it just doesn't seem like it's structurally sound, which is why, as I was sort of thinking about what's the straw man, we should be thinking about the demand side as well. How do we reduce just the pressure, perhaps, and take a longer view on the program? But that's a conversation, and none of us here are pie in the sky type Medicare people. We know how difficult it is for Congress to grapple with very tough choices. All of us were around for the undoing of SGR and how long that took in 2015. And I know that there's not a lot of appetite to sort of delve back into this space, but we're presented with an opportunity, I think, just by virtue of the Part A insolvency issue. And I think we just have to meet the needs of the moment.
That makes a lot of sense. Desi, you had started to touch on this, and perhaps you want to continue your thoughts on what else ought to be considered in terms of improving Medicare while people are thinking about insolvency and trying to address the trust fund. What else do you think ought to be part of that bigger picture?
Well, I think, I mentioned some other options. One straw man was like, well, if you think about healthy people, 20, whatever, pick your decade, 2010, 2020, it's kind of like a public health goal, right? There are lots of different measures, lots of different things that, CDC would put out. And there's an apparatus in the country that gets at meeting some of those goals. Even CMMI would design some of their interventions around meeting the goals of 20, healthy people, 20, whatever. Funders, RWJ, PCORI would design funding, initiatives around those goals. Imagine if Medicare, under some construction, had something like that. And we focus on, say, obesity. I picked obesity because it's like the all-purpose contributor of everything bad in Medicare. It leads to every, you know, whatever the problem is in terms of Medicare spending, obesity is the main undergirding factor. So imagine if we had sort of a unified goal in reducing obesity and looking at that through the equity lens. Who are the most vulnerable? These are some of the costliest people. Or if they're not, they become ESRD, chronic kidney disease. Obesity is one of the predisposing conditions, right? So taking perhaps a more public health view, a longer term view to see if we can get the program on a more sort of structurally sound footing from the beneficiaries' perspective. I mentioned technology. It's hard for me to see a path 30 years from now where technology is not a key part of how we deliver care. We've learned that in 2020. So how do we incorporate that more as part of how we deliver care for Medicare beneficiaries, recognizing I was at MedPAC, I know that we have a real concern around program integrity and having it not be additive as opposed to using technology in lieu of services in person. So, we have some policy work to do to catch up. Providers and, physicians have a lot to contribute in that space. I protest about, lots of ideas that Congress never takes up. Like if you worked at MedPAC, most of what you do, the Congress will never take up. But, I don't think it should dissuade us from continuing to come up with ways to think about reframing our conversation so that they're not a series of short-term fixes to what are structurally difficult problems that we have to address with more compound solutions.
Makes a lot of sense. Let's turn to the pandemic and first talk about how has the pandemic affected the HIA Trust Fund? What do all the various solvency projections really hinge on?
I'm happy to start. I don't think we fully know what the overall changes will be. I mean, there's kind of several dimensions to think about. The first dimension is how is care returned to its pre-COVID pattern. I think the best data says that the last part of 2020 that care really came back to its pre-COVID level. But what we don't know is kind of how much care was avoided, how much preventative care didn't take place that could really cause cost to jump. We don't know how the economy is going to bounce back. The Part A trust fund's really sensitive to tax changes, changes to the economy. We have CBO's best guess right now, but it's very sensitive to those changes. But we really need to, I think, calibrate carefully going forward. The current numbers that we shared are based upon the current CBO projections, but those will change due to better healthcare data, better sense to how the care patterns change going forward. And does the economy, bounce back, quite quickly as what CBO now says, or take more time to get back to its pre-COVID levels? But these numbers will change, they'll bounce, and Congress will have to make the best decisions going forward, given very changing knowledge, data circumstances going forward.
I think you're on mute, Gretchen. Sorry, you're on mute.
Thank you, Des. So questions more around a pandemic are also in terms of how it's changed views in terms of payment arrangements, in terms of how it's affected various providers. Let's start with payment arrangements. Are providers more open to different types of payment arrangements now? Has the pandemic really opened those doors a bit more?
I think I'll start. I think that's the expectation, right? That providers, especially those who suffered really reductions in their revenues, may be open to different payment arrangements that may help smooth out their revenue. So this could be an opportunity to go down that path more. On the flip side, I think there's some concern about even further consolidation of providers moving forward.
Yeah, I think so. I don't know if they're expecting different arrangements, but my sort of takeaway from lots of different conversations is they're certainly expecting to be paid. They want to retain some of the new provisions that came about due to the public health emergency declaration, which sort of, I don't want to say opened the floodgates, but opened up, the opportunity to bill for telehealth. What I think providers don't grapple with as much as a point I alluded to earlier, which is the program is already stressed. And even on the commercial side, there's very little interest in payers paying for yet another way to just sort of add and add and add to care that has no demonstrable impact on health outcomes. And because that's sort of the definition of waste. And so while we believe in the value of opening up access points to care that are perhaps not brick and mortar, that should be less expensive, at least fixed costs over time should be coming down. There's no, I think providers grapple less with the program integrity question, which is that's a problem for policymakers, because that's part of it's probably the main reason for the reticence around, at least in the Medicare program, the reticence around sort of opening up the gates to telehealth. So there's still a lot of room for a meeting of the minds and what this looks like, moving forward.
I think that one question that's not known is, do Medicare beneficiaries believe that they can get better benefits by joining private plans rather than the traditional Medicare program? And during COVID, private plans had more flexibility than the traditional program to offer supplemental benefits, to offer more telemedicine benefits. They're covered by fee-for-service. They could provide meal support, transportation support. So I think one question might be too, do beneficiaries believe that they can get better benefits, more benefits that would kind of help navigate the kind of pandemic response rather than the traditional fee-for-service program?
That's a great question. I want to make sure we get to this, and we've gotten a lot of questions on this, is actual funding for the trust fund and general revenues in general. And this was one of the most in the recommendations that we had Medicare thought leaders put together for the Commonwealth Fund. One of the most frequently recommended ones was essentially redirecting the net income investment tax toward the trust fund and essentially providing a new source of funds for the trust fund. I'd like to get the panel's thoughts on what's sort of the appetite for increasing payroll taxes, redirecting existing taxes. Should we be thinking about different sources of financing for the trust fund as a whole? Anyone wants to take that up?
Well, I'll start and avoid the question, but when there's a gap, there are two options, right? Reducing the expenditures or increasing the revenues. So it's appropriate, I think, to consider some of these ways to increase revenues to help reduce that gap.
I think the question that Congress really has debated, I think, the past 15, 20 years is kind of what kind of mechanisms should be considered to really think about checkpoints or kind of stopgaps when those triggers get met. The Part A trust fund has kind of very precise triggers. The kind of solvency date creates real consequences. Part B doesn't have those, and Part B gets just continuous funding coming from current general tax sources or federal deficit spending. So I think the question really is kind of how to finance, but does Congress need to have new measures, different measures to really create those checks, those kind of stopgaps to really assess the overall program?
So I don't have much to add, Gretchen. You can probably tell this is one of those questions. It's just a minefield. The only thing that I would add is that, you know, it's not either or, right? The Congress should debate not just savings, you know, that we can realize in the program, right? And how we can reduce, I call it reducing sort of pressure, expenditure pressure on the program, but also on the revenue side. And we didn't talk very much about that. And this is probably, I don't know, I'm not the one, I suppose, to lead that conversation. So a different group should really weigh in on what should we do about financing, you know, on the revenue side, what additional sources of income should we be thinking about? The one thing I will say, so it's not either or, but the one thing I would add is that new monies funding a program that is structurally unsound to meet the needs that we know are coming in 20, 30 years is not a solution. It's just sort of delaying the inevitable. So consider both, but we should be really having a much tougher conversation around what is Medicare, you know, 30 years from now? What should it look like?
Well, thank you all for really trying to deal with that tough question. I appreciate it. So we're at the end of our time. I want to thank you all for your insights on this. And thank you for your really excellent presentations. This has been a really terrific panel. For our audience, please take time to complete the evaluation survey, and also a recording of this webinar and additional materials will also be available on the Alliance's website. Corey, John, and Adeze, thank you again for joining us. This has been absolutely terrific.